we want to look at how one area can affect another. So let's say, and just pull that up a little bit. Just pull the shirt up a little bit. Leave the other one down. We are going to create a hip stiffness. Because what is the cost or issue if someone has hip stiffness?
Compensation.
So they might, how would they compensate at the hip? Thank you.
They might hip hike in order to promote flexion.
I've done this in yoga before where they strap my hip up like this.
All right. Why'd they do it?
Yeah, they wanted to see if people, usually you'd rip it if you weren't in certain poses. I remember ripping mine a lot.
Like I'm wearing a leg cycle.
Hopefully we'll be able to get you out of this.
It's okay, I'll just buy a new pair of leggings. We'll be good.
Okay. So what movement issue did I just create?
External rotation.
So, okay, don't go so specific. Don't go so detailed.
Make her pigeon.
What did I here? Just step in place so they stop looking at all. Okay. What did I just do to her overall system? I stiffened what?
Pelvis.
The hip. So now, if Sandra were to go pick that up, go ahead and try and pick that up. Perfect. Now stop. Okay? Back up a little bit. Face this way. Pick up this box. Here's your mover. Pick up your box. What's happening here?
Lumbar flexion.
It's all lumbar. So what did I just create? Say it again. I created what? Hip stiffness. So if the person has to move and they have hip stiffness, they have to move somewhere else. So if this person is doing repetitive movement, go ahead and pick that box. You can even bend your knees. Oh my goodness. That was even more dramatic than I expected. But all right, bend your knees a little bit, but then still do what you did.
Okay.
And they are constantly doing this kind of low back flexion. Or, let's put you in the chair. Come on over. All right, have a seat. Here's the desk worker with stiff hips. What's going on? Well, before a sacral sitting. So what's the movement thing that's going on?
Pelvic.
Lumbar flexion. So, come stand up so you don't stay that way too long. So what's the hypo region? Hip. What's the compensatory hyper region?
Lumbar.
Lumbar spine. Now in this pattern, we just demonstrated a limitation into hip flexion, which caused a hypo-moving lumbar spine into lumbar flexion. So if a person is functioning like this, what sort of PA do you think they're ultimately going to present with? A herniated disc of the lumbar spine. Okay. So you can see how we have the region of limitation and then a region of hypercompensation that very much could relate to a pathoanatomical diagnosis. If you're lucky enough to get this person either early on or even as a preventative eval, you may be able to put them on a path to be able to prevent this. But it's not uncommon that you're getting the person post-injury, but they still have this pattern that led to it. Okay. I think I've taped you up well enough for the next one.
Yeah.
Hold on a second. All right, let's move this here. So now I specifically went for that pattern, which is that flexion-based pattern. But now let's turn this way. Can I pull the sweatshirt up? Is that okay? So they can see your low back. Okay. So now go ahead and take a step forward with your foot. Okay, what do we have here? Okay, now do step with the other foot.
There's no.
So where is the hypo region coming?
No.
The hip. What are we lacking in the hip? Extension. So how is our patient here compensating? Extending what? Lumbar spine. Okay. Now, what patient do you think this would affect a lot? Spinal stenosis. Now, what your question was going to be is, wait, how old are they? Because depending on how old they are, this may be someone who ultimately presents with SI dysfunction, Or if it's someone who's older and has some stenosis, this is the person that's coming in complaining of low back issues. But what are they going to really come in complaining if they have central stenosis? Bilateral what?
Numbness and tingling.
So they might get numbness and tingling. They'll usually get bilateral leg aching and calf cramping. And the reason is, let's go for a walk. Jam, jam, jam. They're already a stenotic area getting compressed, and then they have pain. Right? So then what do? Ow, my calves are cramping. I just walked 3 blocks. What am I going to do?
They lean forward.
Lean forward, because what happens when they lean forward? Decompress it. Have a seat. Now, the tape job would limit flexion, so that it wouldn't be as much. But even limiting that, we have that stiff, crunchy hip. Have a seat. Now we're at least deloading the spinal stenosis. So how are you going to treat this?
Strength and hip extension.
Yeah, you start up when you want to start, like the bottom of the chain, go back up, like where it starts.
Well, I mean, so you're going to look for the clinical priority regional interdependent area known as the driver. So you would start wherever that area is.
Smoothness on that.
The smoothness, right? Worked on that for a while. So you would start at the hip, but you want to relate it to their specific issue. You have someone who has central stenosis. You know that the pattern of irritation is extension pattern. So you're not going to stretch them into hip flexion. You're like, oh, they most likely have glute trigger points and glute spasms, right? So you're going to say, oh, okay, let's stretch out that glute piriformis and bring your knee to your chest. No, that misses the mark on the clinical priority. They might need that, and guaranteed if you release that, they're going to feel better for about 5 minutes. But their clinical priority is get that hip extension. Because if you get the hip extension, then they're going to be able to move and put less pressure to the lumbar spine. So we just watch this person walk, and immediately we see the stiffness. So we only have, we only have a few more minutes in our session. So just from seeing that, knowing that our patient has central spinal stenosis, what do we want to do? Take the tape off. Yes, we want to take the tape off. So let's say the tape is articular or deep muscular. What are we going to do? Sorry? Well, we have 15 minutes. So we want to get the most bang for our buck. So what are we going to do right now? All we saw was this. It's a 20-minute session. Structural barrier differential. How do you want to do it?
We'll have her lay down, see if she can, how far she goes active.
All right, go ahead and lie on your side, face away.
I know, I'll like
Very impressive. Okay, now there are a variety of different ways that you can do this. Treatment side lying of someone with spinal stenosis is a very effective way to do it. All right, so what do you want me to do?
first see how she can kick towards you.
Okay, extension towards me?
Yeah, like you'd say, can you bring your heel to the
Okay, bring your leg back towards me. What am I seeing?
Extension lumbar spine.
Extension of lumbar spine. Does that match my theory about why she has pain in standing?
Yes.
Is that something that I would want to change?
Yes.
Absolutely. What do I want to do now?
Check to see the end field.
Check the end field. Because we don't know. She just did this actively. So is this her active control issue? Or do we have a hypo-moving hip? And they use that term on purpose. Because we don't know if it's muscular or articular, or directional articular or positional fault. All we know is that there is a hypo-moving area and a compensatory area. So we emphasized active limitations in the past, looking for drivers trying to gain control. So right now what we're talking about is a passive limitation. And we will check that. We will hold on to that pelvis, and we will monitor the hip, and we will try and extend it, and we'll say, that's about as far as we can go. And then we will apply our structural barrier differential. The first thing that we'll do is we'll do an overpressure to get an end feel. And then we will do a joint move to see if all of a sudden the motion improves, because that would be what? Positional fault. Or we could do it, maybe it improves a little bit, but not a whole lot, but the end feel is that they have a firm, non-giving end feel. What am I thinking? Capsular, and the term that we're using is directional capsular, because they are stiff in a specific direction. If we do overall distraction, and there's no play, what am I thinking? Overall capsular tightness, known as a capsular contracture. So I would treat a capsular overall contracture differently than I would a directional capsular limitation. I can use distraction to treat anything, even a painful joint. But if you have someone who has their entire capsule that's kind of shrunk in, it's different than if you have one area that maybe had some scarring and has some limitations that I would want to do a directional mode.
Might that also present differently, so they would have limitations in multiple directions?
Yes, yeah, so they might present with a more obvious capsular pattern, but I'm targeting my patient's specific limitation, which in this case is extension, which I know goes a bit against the traditional capsular pattern, but the newer research is starting to imply that loss of end range extension might be early signs of hip OA. So checking that end range extension is very important from a preventative standpoint. And now you have this patient who has a crunchy hip, so it's probably hip OA, stiff, that's ultimately ended up with some central spinal stenosis. So you're probably ending up with some kind of capsular pattern. Okay, but we're emphasizing the extension despite the rules of capsular pattern.
So just to clarify, you said, yeah, the directional capsular, you are gonna treat different, like we just said, than the overall. And we haven't gone over, that's what we're, this, okay.
Yeah, so there's gonna be some of what's coming, and this differential is actually written out further down in your slide, but it was kind of flowing right here, so I figured I'd just kind of go over it. So basically from this, you would do your structural differential. You say this is the hypo-moving area. So I'm gonna mobilize it, or if it's muscular, how would it present if it's muscular? What's my end feel when I push like this? So springy, and I know springy is the term that we've used. So board's clarification. For the most part in American physical therapy world, springy implies cartilage. So if you do an end range knee flexion, and on the boards they describe you get a springy end feel, highly likely they're talking about a meniscal tear that's getting caught. Okay? The reason the term springy, and what really the way it's been presented as firm but springy, is because muscles feel that way. So if you do an end feel and it's non-giving, it's firm, non-yielding, you're like, ugh, ugh, that's capsular. But if you get a firm end feel and it's like, it has a little play to it, so that's why the term springy was used. But it's really firm and giving, now you're thinking muscular. Okay? So what's in a word? As long as you understand what you're feeling, then it's okay. However, looking at kind of board's review questions, I saw this as a potential problem. So I wanted to throw that out there, that springy, as far as the boards are concerned, usually you should think cartilage. Okay? So from this quick follow through from what we saw in function, get on the mat, do your structural barrier differential, you say, I'm gonna do a joint mobilization. So a patient lies prone. Go ahead, now, what would be the precaution? I'm switching hips just because I'm over here. I'm gonna do an anterior mobilization because I want to improve hip extension, or I want to do the figure 4 mobilization because that's gonna help overall loosening, and it's gonna help an overall hip extension. What's my risk?
Dislocate.
Oh, no, not in this patient, but yeah, you always want to be aware of that, but not on this hypomobile patient.
Peripheralization of pain?
What's that?
Pain peripheralization?
Pain peripheralization, why?
Because you're putting them further into extension?
What's happening when I lift the leg?
Extending your back.
The lumbar spine is extending.
Hmm.
So you want to keep your patient's pattern in mind and put a pillow under the abdomen. Couple pillows, and I'll just lay down.
Cause it'll like set them up.
It sets them up in flexion, so now we have plenty of room so that as we extend the hip, the lumbar spine will extend a little bit, but we're not going to compress the lumbar stenosis. That frees us up to really get in there and keep checking in on our patient and realize, is that doing okay, is that doing okay? Okay? There's a 20-minute treatment. Someone comes in, diagnosis spinal stenosis, you watch them walk, there's a stiffness, you get them on the mat, you say regional interdependence, yes, you don't have the extension, I see that it's articular, I want to do a joint mob, let me set up the precaution so that the low back is protected. Now face me. I mobilize the hip, I gain some hip extension. What do I want to do for the low back? Straighten your leg. What's that? Yeah, well, maybe not minute. If they were hypermobile, I might. But I want to stretch, mobilize, or muscle energy into flexion. Let's deload the area. Maybe we start with some traction, maybe we do some flexion moves. Let's open this up. Because they are compensating into extension, so they're real stiff in extension, so I need to open them up into flexion so they have more room to move. I mobilize them into extension so that the hip can move. Now they're going to be a lot happier. They're already coming in compressed in the low back, so let's open this up. Go ahead and lie on your back. I'm going to teach them the typical knee to chest to flex the low back so they can get some relief, or sit on a chair, reach for your ankles to open up the low back, explain their pattern. This is all done in 20 minutes. What am I doing on the next section?
Reassessing.
Reassess. Probably doing the same treatment because I'm not going to loosen up that capsule in one session. And highly likely they recompressed a bit in their low back. So I'm going to do the same thing, but I already know it. So there's 7 minutes. So now what's the rest of my treatment, because I want to continue to progress their movement pattern?
Strengthening. Strengthening to
Maybe a
harden.
functional exercise, but why are they going into extension? So they're compensating.
I feel like you should do where the TA, like, something.
So
to
maybe
unload it.
they are compensating by going, but they are compensating by going into extension. So I gave them more hip motion, so that's helpful. But now we want to start to teach them about their abdominal core. So we do, if they can connect to them on TA, great. If you can't, it's okay. Sometimes we just teach them about pelvic tilting. We do teach them a bit of a bracing strategy, because now drawing through here, hang on, lift this leg up. Now you want to maintain the pelvis where it is as this leg goes where?
Into extension.
Into extension. So we are now training their abdominals to prevent the main give, which is lumbar extension, that relates to their PA, and then training their movement, the hypo area, so they can start to get into extension, because our goal is, go ahead and lay on your stomach again. Engage the low abdominal, posterior pelvic tilt, maintain this opening, teach them about the compression, use your glute, lift this leg into extension. Or this one. Okay. So you see that? There's session 1, 2, maybe 3. Each time they come in, I already know I'm mobilizing the hip. That's going to take some time to loosen up. I'm most likely going to decompress their low back because they're most likely re-irritating that throughout the day. But now I'm going to treat their movement. So I can do that real fast, just simply based off of my clinical reasoning. If I have a little more time, driver assessment. Maybe I can, bless you, determine if they can handle a bit more of a motor control challenge or a bit more of a stability challenge. But what you want to have is a clear, quick stream in order to be able to handle this person that has a very obvious regional interdependence. Okay. All right, let's move on.
Go for it.
No, I meant
Would
the
you
tape.
also describe, like, would you also have them, like, when they were at home, like, would you say, like, to lay on some